Good afternoon, everyone. Welcome to the GAID second day of GAID Annual Congress. Hope you are enjoying your weekend, and I hope you had a fruitful and informative day yesterday with our first day of the Congress. Please feel free to go from the different tracks through the different tracks. Today we're going to have the diabetes track, the adrenal and pituitary track, and the third track is for the pediatric endocrinology and adolescent. I wish you a very fruitful rest of the evening. Thank you.
Bismillahirrahmanirrahim. Wassalatu wassalamu ala ashrafil mursaleen. I welcome all of you in the association, Gulf Association of Diabetes and Endocrinology, and the session of the diabetes session. It will be by a speaker from the Saudi Arabia and from the other part of the Gulf. And I will share this session with my colleague, Dr. Muhammad Bashir from Qatar. And the first speaker, he will be Dr. Saud Al-Sifri. He's going to talk about the standardized CGM report. Dr. Saud Al-Sifri, he is associated professor in Taif University and consultant endocrinologist, internal medicine in Al-Hada Armed Hospital. He's trained in Canada, endocrinology and internal medicine. Also, he's a co-chairman of Saudi Diabetic Society. And he's going to talk about the standardized CGM report. I welcome all of you for this session. The session will be shared by me and Dr. Muhammad Bashir, and he's going to present the other colleague, and hopefully, inshallah, we'll meet you at the end for the discussion. Dr. Saud, the floor for you.
Assalamu alaikum wa rahmatullah. Thank you very much, Professor Abdurrahman. Thank you very much, Dr. Muhammad Bashir. I'm very happy to be here with you. Again, I would extend my thanks to the scientific committee for having me with you here. And I wish that we are going to have a very pleasant presentation. I'm going to talk about really the standardized report for CGM. And I would have really like reporting and analysis of those standardized metrics that I'm going to have in this meeting. So with this, I would start. And again, in the coming 20 or so minutes, I'm going to talk about those standardized CGM reporting and how we would use it. This is just to go back into October 2000. That was the time for the first child who was started on insulin pump therapy in Saudi Arabia. And then I'm going just to have a quick literature review for those who are in Saudi diabetic children, how and when we have used the time and range and the continuous glucose monitoring in those pediatric children. Now we have been using the continuous glucose monitors in the last 20 years, and now it has been reaching a stage where almost everyone who's of type 1 is using it. Now we have got different types of CGM here in Saudi available, the real time, and the other one, which is intermittent scanned CGM, and the blinded CGM, and then the unblinded CGM for our people. Now, before going into the standardized reporting, we have to know what was the benefit of using the CGM. And I think it has been seen in terms of variability reduction, and again, in increasing the time in range for those glycemic control and decreasing the hypoglycemic time in range and improvement in quality of life that we are seeing. So the good thing about CGM that it displays all those numerical as well as geographical information about the current and instant glucose level that we are seeing, again, having a trend that would help physicians and healthcare providers to have a better pictures of those. Then again, downloading those retrospective data, it would give you better analysis for them. Now, some of those features of the glucose continuous monitoring is really having an alert or having the data sharing where they can share it with their either parents or their care partners who are doing with them. Now, having a trend arrows that would help patient again to make a daily decision on them doing that. Now, how we would have this reference, again, this is just to tell you that with the difference that we are seeing, I'm trying just to catch those, yes, so that it would show you. So here with the different CGM that we have got, it would show you what are the reference for those arrows, whether it was horizontal or it was vertical or it's taking 45 degree. What does it tell you in those patients? Again, for the clinical practice, these are some of the different CGMs. And again, in this, you would see that what are those guide that they might need it in their clinical practice. Now, again, having ambulatory glucose profile reporting is very important. So here it would tell you that time in range, or those who are above time in range, or those who are got below the time in range. And this can tell you how much of the glucose variability. It can be either in this report, or it could be in this, what we call it a graph, where it showed you the median of 50% of them. And then here it would tell you what would be the range that they might have, either in the 90 or 75%. Again, the more variability that you would have, again, the more risk of hypoglycemia that your patient is having, or hyperglycemia that they might have. So here, this is the time and range for time above range, and here is the time below range in those population. And this tells you how much of this percentage has been above the target or below the target or within the target for each individuals, either over 24 hours or over 14 days, or the wear time for that CGM. So in summary, it showed you that the review summary of those, it would tell you that here, for example, this patient, that it had the goal for less than 36% of the time. And here you could see that in 76% of the time, it was time in range. This is what we want. So these are the metric that whenever we are reviewing those ambulatory glucose monitoring, that the data, at least it has to be for 2 weeks, and then the percentage of time that they are looking for, and the coefficient factors, and the indicator, or what we call them glucose management indicators for those. Remember that CGM or having no calibration in that does not mean that they don't need to do glucose monitoring or a glucose check with a finger stick, because at some situations where you have got hypoglycemia or rapid change in the level of blood glucose, or you want to have a pre-confirmations for certain of this, or if you feel that patient is having symptoms which is not related to the real reading, then that patient might need to do glucose check by themselves. Now, for the data interpretations, again, we have got few steps. Remember, those 7 steps are important, that at least the data is enough, and then having the patient to have their daily self management, what they have been doing, and then what do they think of this AGB reporting, because it comes in different color, and then to look into the hyper, and then variability that your patient is having. And again, to be reflected that what do they think the cause of these, either high or low blood glucose, and then to develop in collaboration with the patient an action plan for that, and to make a copy with remarks on those one. Now, the recommendation comes from the international consensus on time on range and using those continuous glucose monitoring data interpretations. So the interpretations, again, these are very important. It is a common metric for assessment of the CGM glycemic status. And again, it can tell you the visualization in a graphs about the glucose data and the daily profile that it has got. Again, defining a clear clinical targets are very important. We have to remember that a lot of things can be dated from there. How many days that the CGM has been worn, and what is the percentage of time that it was active, and what was the mean glucose and estimated A1C is very important. It can come from those repeated data and continuous data of glucose. Then the glycemic variability is very important, and the time which is above range, and in that you have got two targets. In this one, either it is more than 250 or more than 180 milligram per deciliter, and those time in range, or time below range less than 70, or critically below time in below the target, and that's less than 54 milligram per deciliter. And then we have to look into those low or high blood glucose indices. Then the hypoglycemia and hyperglycemia, which has been more than 15 minutes, has to be reported. And then those area under the curve has to be time. Then the time, you could see it either at 12 hours period, which is either those had been in day or night, so in 12 hours, or collectively as 24 hour. So the standardized CGM metric for those clinical care, it has to be remembered that how many of this has to be. So the time above range has to be either level 1 or level 2 based on the target above the range, if it is more than 250 or more than 180. And time in range, it's between 70 and 180 milligram. Below 70, it is level 1, and below 54 milligram per deciliter, this is level 2 for the time below range. Now, we wanted to see what happens with those time in range, or below range, or above range. So here for type 1 and those with type 2, we wanted to have them more than 70% of the time that they have got time in range. Time below range should be less than 4%, and time above range less than 25%. Now, for those individuals who are elderly or who has got a high risk for hypoglycemia, in that we wanted to be more than 50% time in range, and we wanted to be less than 1% time below range, less than 10% time above range. So this is an important in those elderly or high risk for hypoglycemia, whether type 1 or type 2. Now, another category, which is a pregnant lady with type 1, this is again, we wanted more than 70% time in range, and we wanted to be below range less than 4%, or those less than 25% time above range. This is just to show you that, again, in type 1, type 2, this is what we wanted, more than 70% in the green zone, which is time in range, and here not to exceed 30%, while here less than 5%. Now, when you talk about those high risk or elderly for hypoglycemia, then again, this is what we are talking about, more than 50% within the range, time in range, and less than 50% or less than 60%, they should be within time above range, and less than 1% in hypoglycemia. Now, type 1 pregnant, this is what we wanted, more than 70%, they should be time in range. And for those pregnant, either gestational or type 2 diabetes, we wanted really to be more than 90% within time in range. So these are important, and this is now, it is reflected in time and range, is reflected in the estimated HbA1c, which we could get it from there. Now, these are glycemic glucose management indicator, which might be a new term for the estimated A1C, which we could extract it from the continuous glucose monitoring. Now, the relation between the HbA1c, which is the measured one, And the relation to time and range has to be remembered that here, when you talk about almost 70% whom they have been on time and range, it means almost it is equivalent to 7% of A1C. Now, this is a very important predictors. So remember that when you talk about 50% time in range, we're talking almost about A1C of 8%. So reaching more than 80% of time in range is equivalent almost to almost 6.5% HbA1c. Now, in this, again, in type 1 and type 2, here, if you would see that if we talk about 60%, we are talking about A1C of 7.5%. And always remember that whenever we get increase in 10% of time and range, we are getting almost like 0.8% reduction in A1C calculation. So this is important. We wanted to validate now the time and range, or using this reporting of standardized continuous glucose monitoring as an outcome measure for those diabetes clinical trials. So here, remember that we wanted to evaluate the association of time and range with the developments and progression of those microvascular complications like albuminuria or retinopathy. So in this, they have been taken 1,440 patients, and they wanted to see in this. So the progression of retinopathy was increased by 64%, and developments of microalbuminuria by 40% for each 10% point lower time and range for those patients. So remember that the time and range has been well linked to those microvascular complication linked. Again, remember that the better you would have in time and range, the less frequency of retinopathy or microalbuminuria. Here, when you talk about more than 70% time and range, it talks about almost 5% of progression into retinopathy. Here, again, 3% progression into microalbuminuria with those more than 70% time and range. Again, less time and range means more frequency of having those microvascular complications. Now, always into achieving goals, we have to remember that you have to be specific, measurable, achievable, and relevant, and time-bound. So this is the SMART approach. And the goal from here to define exactly what you want to achieve, and you can measure it, and then you want patient not to be stretched, that he's challenged in order to meet these targets, and you want to do it over short period of time. So from this in clinical practice, what we have seen that those time and range or below or above range or within the target range is useful clinical targets and outcome measures, which we have seen in the microvascular complications as complements for A1C for a wide range of people. And again, remember that the target values should be always considered as integral component of the CGM data analysis and day-to-day treatment decision making. Remember always, HbA1c has been used as a gold standard for the glycemic control since we had the trial of DCC, and the SMBG has been a cornerstone of diabetes management care. And this is, we could verify the variability on those daily basis in order to see it. HbA1c does not really distinguish between individuals who have got the same average glycemia, but they have got difference in terms of their risk for hypo or hyperglycemic events. Remember that the SMBG, or having a glucose reading, it's a snapshot of glucose value, but it does not really tell you what was the fluctuations between these tests which patient was taking. So we knew it at that time, but if he takes it another 8 hours later, we don't know what happens in between them. Now, the CGM, the daily one, it provides really ability to obtain an immediate feedback on the current glucose level, as well as direction and rate of change in those glucose level. Informations of these data allows those individuals with diabetes to optimize their dietary intake and exercise, and to make the therapy decisions regarding the meal time or immediate and appropriate for their healthcare providers to prevent those acute glycemic events, whether it is a DKA or severe hypoglycemia, is very important. So with this, really, I reach my end. Thank you very much, Mr. Chairman. Thank you for my dear colleagues. And I hope that was enough to give you this. Thank you very much for having me with you. Thank you.
Thank you very much, Dr. Sifri, for a very nice talk. So our next speaker is Professor Jason Gill. And Professor Gill is a professor of cardiometabolic Health Institute of Cardiovascular and Medical Science, University of Glasgow. He is actually quite active in research and leads a multidisciplinary research group investigating the effects of lifestyle on the prevention and management of vascular and metabolic diseases. Usually, he's mostly interested in the epidemiology. He's usually of lifestyle and cardiometabolic disease risk, and on lifestyle intervention for the prevention and management of cardiometabolic disease. And Professor Gill is actually a celebrity. He features quite not unfrequently on BBC documentaries, which I did enjoy in the past. And I'm sure we're going to enjoy his talk today, which is titled, Is Seating and New Smoking? Professor Gill, the stage is yours.
Thanks, Dr. Bashir. I'm delighted to be here. So to start off, I'd like to say that physical inactivity is a really big health problem. If we look at data from the that was published in The Lancet about a decade ago, what we can see is there's a similar number of deaths annually worldwide due to physical inactivity as there is due to smoking. So physical inactivity is a big deal. And because of that, there are guidelines for how physically active we ask people to be. There's various guidelines from various organizations. These are the most recent. These are the World Health Organization guidelines. And they really have three components. The first is to undertake what we call moderate to vigorous physical activity, doing at least 150 minutes of moderate intensity physical activity or 75 minutes of vigorous activity. To do some muscle strengthening activities on at least 2 days a week. And then finally, there's this fairly vague thing about limiting the amount of time we spend sedentary. And this is not really well described. So what does this mean? And should we worry about how much time we spend sedentary? And I'm just going to talk about that a little bit over the next few minutes. So the first thing we need to consider is, if we use this pie chart and say, this is what the day looks like. So we sleep for about a third of the day, for about 8 hours. And if we meet the moderate to vigorous physical activity guidelines for, we'd be doing moderate to vigorous physical activity for about 2% of the day. So a question is, does it matter what we do in the other 2/3 of the day? And what we can do in the rest of the day is broadly three different things. We can either sit down, like I'm doing now, we can be standing up, or we can be moving at light intensity. So one of the key questions is, does it matter what we do in that part of the day if we are doing our moderate to vigorous physical activity? If we're doing our 150 minutes of moderate intensity physical activity per week, does it matter whether we spend the rest of the day sitting down? So what do we mean by sedentary behavior? So sedentary behavior is characterized as any waking behavior, so not while you're asleep, where you are expending a low amount of energy. So the energy expenditure is less than 1.5 METs or metabolic equivalents, where a MET is the amount of energy you expend at rest, and you need to be sitting, lying, or reclining. Is this a big deal? Now, if you look at the internet, they would suggest that it is a big deal. I just had a quick look when I was preparing this talk, and you see all these different, very well put together graphics saying sitting is the new smoking, and we should be really, really worried about how much time we spend sitting down. So what I want to consider over the next few minutes is whether the evidence for sitting actually fits with the rhetoric that we see in the popular press. So the first thing we really need to consider is how much sitting is needed for adverse health outcomes, and is all sitting we do beneficial or harmful, or is there a minimum amount that we need to be beyond before we see increased risk? And if we look at the data, this is a meta-analysis that was published a couple of years ago, and what we've got here is on the y-axis we've got relative risk of mortality from all causes, and on the x-axis is how much time people spend sitting down. And one of the things that you notice is the relationship is not linear. It's curvilinear. So the first 8 hours or so you spend sitting down, you get no increase in risk. And then beyond 8 hours, every extra hour you sit down is associated with about a 4% increase in risk of all-cause mortality. So one thing I like to say is you get the first 8 hours free. And this differs from maybe what some of the rhetoric is, that all sitting is bad. So sitting for 8 hours, it doesn't really matter what you're doing up to that point. It's only beyond that where we see an increase in risk. One of the key things is people underreport how much they sit by about 1 to 2 hours a day. So if you directly measure how much people sit, they underreport it a little bit. So what does the relationship look like when you directly measure how much people are sitting using an accelerometer, which is a device which can measure your body's movements? And Ulf Eklund did a meta-analysis in 2019, and what you find is it's broadly similar data, but the amount that you need to sit before you get an increase in risk is about 9 hours a day. So sitting for about 9 hours a day seems to give you no risk, and then beyond that you get an increase in risk. The other thing to consider is how much people actually sit. So, and this is data from the United States. I'm not sure what the data would look like in Gulf states, but the average adult is sitting about 6 to 8 hours. So a large proportion of the population are sitting an amount which might not be as hazardous as we think. The other thing that we need to do is really put this into perspective. Let's say, for example, you've got somebody who's sitting 10 hours a day. They've got increased risk because they're sitting more than 9 hours a day, and they reduce their risk to 9. They reduce their sitting by 1 hour, so 1 hour less. And what you find is that change in sitting is associated with about a 17% reduction in risk of all-cause mortality. Now, if we get people to walk for 2.5 minutes more, that's also associated with about a 17% reduction in risk of mortality. So on balance, sitting for an hour less is equivalent to walking for 2 hours, walking for 2.5 minutes more. So one of the things that we really need to take into consideration is that you can offset the amount of time you spend sitting by moving more. And the open question is, which of these is easier to do? And I'm going to talk about that a little bit further on. The other thing that we really need to think about is this slide here. On this side shows risk of mortality with the amount of time you spend sedentary, and on the other side it's the amount you spend in light intensity activity, which is the low intensity activities that you'll perform when you're sort of moving around throughout the day, and they're essentially mirror images of each other. So some of this is to do with framing. Is sitting bad, or is sitting just marking someone that's not doing low intensity movements throughout the day? A final point that I'd like to make conceptually is that a number of studies have looked at TV viewing as a measure of sitting. So what they do is, in a questionnaire, they ask you how much time do you spend watching television? And that's not the same thing as sitting. And if you look at the relationship between sitting and mortality versus television viewing and mortality, what you find is the relationship is quite a lot steeper for TV viewing. And so there might be a public health argument to say we need to reduce the amount of time we spend watching television. But if you say this means that you have to reduce all the amount of time you spend sitting, I'm not sure that the evidence is particularly there for that. And one of the things that we really need to think about is if you look at the correlation between the amount of time you spend watching television and the amount of time you spend sitting, it's actually a really poor correlation. About R is 0.1. And the other thing is TV viewing, as I'm sure you're all aware, is heavily confounded by dietary intake. So people, when they're watching television, will eat crisps and drink fizzy drinks. And what you might be measuring when you're looking at the adverse effects of TV viewing is actually the adverse effects of this combination of adverse behaviors. So extrapolating that to all sitting, for example, sitting in occupational activities might not be necessarily the case. And sitting is also heavily confounded by other factors like socioeconomic status. So I think we need to be very cautious there about how we extrapolate. But let's move specifically now to type 2 diabetes. And if we look at the association between sitting on the x-axis and risk of type 2 diabetes, it's actually a relatively flat relationship. In contrast, the relationship with television viewing and risk of type 2 diabetes is quite steep. So I think there's a logical case to say we want to try and ask people to limit the amount of television they watch to reduce risk, but maybe not for overall sitting. And the other thing that's clear is if you look at the size of the relationship between what's the association between every hour of sitting and the increased risk of diabetes, what you find is every hour of sitting you do, extra hour, is associated with about a 1% higher risk of developing type 2 diabetes. Whereas if you look at the same data for physical activity, and I won't go through the whole slide here, but basically every minute of physical activity you do is associated with about a 1% lower risk of developing type 2 diabetes. So again, we've got 1 hour of change sitting by 1 hour or change physical activity by 1 minute. And I'm going to argue that changing physical activity by 1 minute is an easier thing to get people to do than getting people to sit less for 1 hour. Another thing that we need to take into account is the adverse association between sitting and risk of adverse health outcomes seems to differ depending on how physically active you are. So this is a meta-analysis published by Ulf Eklund and colleagues in a few years ago. And what they did is they looked at the amount of physical activity people did. So we've divided populations here into 4 levels of physical activity. This is the most active quarter of the population, next most active, and least active quarter. So the least active quarter of the population are doing less than 5 minutes per day of self-reported moderate to vigorous physical activity, whereas the most active are doing more than 65 minutes. And one thing to look at is when you look at these data, if you are active, this is people that do less than 4 hours of sitting, 4 to 6 hours, 6 to 8 hours, or more than 8 hours, the relationship's flat. So no matter how much sitting you do, your risk of mortality is about the same. Whereas if you are very inactive, sitting more is associated with high risk. So these people here would benefit from sitting less. These people here, it doesn't matter. But a question you have is, if you take this person who is sitting for more than 8 hours a day and not doing very much physical activity, how can they reduce their risk? So one option is, well, if they reduce their sitting by 4 hours per day, so they move from this group here that's sitting more than 8 hours a day to this group here, and they get this reduction in risk. But the thing that you find is that if you keep the amount of sitting they do the same, so more than 8 hours a day, but move to the next group for physical activity, so they walk for 20 minutes more per day, and this is self-reported walking, so it's probably maybe 10 minutes of actually measured walking using an accelerometer, you find a similar change in risk. And similarly, if you take the person here who's in the next lowest group, you get a similar reduction in risk. And one of the things that I'm going to argue is that it's actually quite hard in practice to get people to change the amount of sitting that they do. And option 2, which is trying to get them to increase the amount of walking they do, might be easier. These are data from a meta-analysis on interventions to reduce sitting. So this is a systematic review of all the interventions that have been tried. And what you find is, on average, they're able to reduce the amount people sit by about 30 minutes per day. So not very much. So we're struggling to get changes in sitting that would have a substantial effect on risk. And although people say that a lot of people don't like to do physical activity and getting them to sit less might be easier, what the evidence suggests is it's actually pretty hard. And when you do the proper randomized controlled trials, it's quite hard to change. And I'm going to give you an example with a study that we did, which was called Eurofit. So this is a study that we did looking at top-level football clubs, so soccer clubs throughout Europe. So clubs that you will have heard of, like Everton, Manchester City, Arsenal, Benfica, Porto, PSV Eindhoven. So we took top-level football clubs throughout Europe. And what we did is we tried to get the men who were supporters of these clubs to increase their physical activity, because one of the things that we find is that men often find it it's really hard to get men to become more physically active. And we use the fact that men often have a very strong affinity to their football club. And so what we did is we trained the coaches of the football clubs to deliver the intervention. So it's been about 1,100 men throughout Europe. And one of the things that we did is we tried to get people to increase their physical activity and to reduce the time spent sitting. And one of the things we used, we developed this device called the SitFit, which sits in your pocket. And because it sits in your pocket and your thigh changes orientation depending on whether you're sitting or standing, with the accelerometer, you can work out whether somebody's sitting or standing or not. So just like a pedometer is used to count people's steps, this is really a sitting pedometer, and what it does is it can measure how much time you spend sitting upright. And we felt that using this sort of device could give people targets for how much time they spend sitting, which they could reduce, as well as increasing the amount of walking they did. And what we found essentially was that we changed sitting by a very, very small amount. So at 12 months, we only changed sitting by about 2 minutes. We managed to change walking by about 6 minutes. Again, you might say that's not a huge amount, but I'm going to talk to you about it because this is directly measured using an accelerometer. The self-reported changes were bigger. So people reported that they changed their sitting by 64 minutes and their physical activity by 31 minutes. But when we actually measure it, what you find is the effects are much smaller. And this is one of the reasons why you need to really measure what people do and not just believe what people say they do. But although we had a relatively modest change in physical activity, we did see substantial metabolic benefits. So we got about a 2.6 kilogram reduction in weight. We reduced blood pressure, reduced insulin sensitivity, reduced triglycerides, improved liver enzymes, despite this relatively modest change. So one of the take-home messages there is this: you don't need to change physical activity by a huge amount to actually cause a reasonable metabolic benefits. The next thing I want to talk about is, well, what is the minimum benefit? What is the minimum increment beyond sitting where you see a metabolic benefit? Because you can be sitting and you can be not sitting by standing up, or you can be not sitting and moving. And if sitting is something that you want to avoid, how much do you have to change your behavior from sitting to see a benefit? And we looked at this in a study in some older adults that we published a couple of years ago. So what we did is we got a group of older men and women to come to the lab for three days. On one day, they sat down all day and we gave them a breakfast and a lunch, and we measured their insulin and their glucose concentrations in response to it. And we had two groups. We had white European people and South Asian people. On another day, what we did is for 5 minutes every 30 minutes, we just asked them to stand up. And then on a final day, we asked them for 5 minutes every 30 minutes to walk up and down the corridor. And it's just a corridor just outside there. Just walked up and down the corridor very, very slowly for 5 minutes every 30 minutes. And long story short, what we found is breaking up sitting with periods of very slow walking reduced insulin and glucose concentrations, but breaking up sitting with periods of standing didn't. So it seems the minimum increment over and above sitting to actually cause a benefit is moving, slow moving, and not standing. And other studies have shown exactly the same thing. So it seems that standing up in itself is not sufficient to cause a benefit. You need to be moving. So in summary, what we say is the minimum increment above sitting to give a benefit is moving, and standing isn't enough. So there's implications of this, because some people have standing desks, and one of the reasons people have standing desks is to say we're going to get the metabolic health adaptation, and I think the evidence suggests that's probably not enough. There are other reasons why you might want to have a standing desk, for example, to reduce back pain and things like that. But in terms of metabolic benefits, we probably need to be moving. So I'd argue that saying sit less is actually unhelpful. And I think we should just say that we need to move more, and move more frequently throughout the day. So I'm just going to summarize. So I think the evidence is undertaking more physical activity at any intensity is associated with a range of health benefits. And those include reducing risk of mortality, reducing risk of type 2 diabetes, and actually improving glucose control in people that do have type 2 diabetes. But sitting's not special. It's just one end of the activity spectrum rather than a special case. And intervention data suggests that it's really hard to change people's sitting. You have to do it for a long period of time to actually get a sufficient change to induce a metabolic benefit. And at the moment, we can't really do that very well. And it seems that moving rather than stationary standing is likely to be the minimum increment that we need. So I think standing desks are not really a helpful idea. And I think the idea of saying sitting less, which might get people to do I'd say a suboptimal solution, like using a standing desk, is probably not helpful. So I think accumulating more activity throughout the day is a beneficial thing. So asking people to walk maybe for 5 minutes every hour at a slow pace is a much better approach. And I think having a separate focus and saying sitting is a really bad thing and sitting's the new smoking is not helpful. So I think I'd just like to finish off by saying move more often is probably the message which we should be using for everybody. So that's patients who have type 2 diabetes, people at risk of type 2 diabetes, and everybody in the population, and not just focusing on moderate to vigorous physical activity, but all levels of physical activity through the day. Being a little bit more active throughout the day is consistent with the evidence base, and I think that saying that sitting is the new smoking is really not the most helpful thing to do. So I think I'll finish off there. I think I've kept to time. So thank you very much. And I'll be there with the panel to take some questions later on.
Thank you, Professor Jason, for the nice talk. My colleague. So our next speaker is actually Professor Lee Kaplan. Professor Lee Kaplan is an associate professor of medicine in Harvard Medical School, and is also the director of Obesity, Metabolic and Nutritional Institute in Massachusetts General Hospital. His research interest. It's my pleasure to introduce Professor Lee Kaplan, and I was mute, so thank you, Professor Gill. So Professor Lee Kaplan is an associate professor of medicine. He's the director of Obesity, Metabolism and Nutritional Institute in Massachusetts General Hospital. His research focus is mostly on the role of gastrointestinal tract and gut microbiota in the regulation of energy balance and metabolic function, and the mechanism of action of bariatric surgery and genetic determinants of obesity and its response to therapy. Professor Kaplan, the stage is yours.
Good evening. It's a pleasure to join you here from Boston. I wish I could be there, but we'll do that in another year. I'm going to talk tonight about GLP-1 agonists in the treatment of obesity. Now, I want to start by emphasizing that obesity is a disease in the classic sense. It results from abnormal physiology, which is caused by changes in the modern environment acting on individuals with susceptible genetics and biology. It's similar to other modern epidemics like allergies and autoimmune diseases, which have become epidemic because of changes in the modern environment, but are diseases because those changes change the internal immunology. In the case of obesity, it's the internal metabolism and the normal regulation that is disrupted by the environment. Like other diseases, it occurs inside the body, even if some of the causes are outside the body. And it's not a condition of choice. It causes pathology, it diminishes health. And as with most other diseases, the patient's job is to seek and engage with care that is based on improving that abnormal physiology, that pathophysiology. Wishfulness and willfulness alone are rarely successful when you have obesity. Now, we're not talking about a few kilograms to lose. We're talking about true obesity, which is excess body fat that causes a risk to health. Now, effective obesity treatment then requires restoring normal physiology. It frequently, but not always, benefits from a stepwise approach, starting with self-directed lifestyle change at the bottom of this pyramid, moving up to professionally guided lifestyle change, which is the same thing, but a professional to help the patient is added into the mix. Then proceeding, if needed, to pharmacotherapy, and in some patients, surgery and post-surgical combinations, surgery and devices, surgery and medications. But the effectiveness of all anti-obesity therapies, including surgery, has generally been limited. And more importantly, even the most powerful show a very profound patient-to-patient difference. So, for example, with bariatric surgery, patients lose as little as 15% of their total body weight and as much as 60% of their total body weight. And we can't yet predict who's going to be in which category. So the effectiveness of all anti-obesity therapies has been fairly static over the last 60 years. If you look here at bariatric surgery, it was as good effectiveness-wise in 1960 as it is today. The safety has improved very dramatically, but the efficacy has not changed significantly. Intensive lifestyle therapy, the same thing. That's much less effective on average. It's about 4 to 5%, or it leads to about 45% weight loss. Again, it's been made easier and more routine, but it hasn't been made better. Drugs, the same thing. You can see that drugs in general have caused about a 5%, maybe 6% weight loss. There was a blip about 25 years ago with fen-phen. But again, drugs are about the same in terms of effectiveness, or have been, as intensive lifestyle therapy. Well, we'll come back to all that in a few minutes, but for now, I want to emphasize that for this talk, I want to talk about GLP-1, glucagon-like peptide 1, which is an important therapeutic target in obesity. It's a 31 amino acid peptide. It's secreted predominantly from L cells, enteroendocrine cells in the gut mucosa. It's also secreted by neurons in the central nervous system, particularly in the hindbrain nucleus tractus solitarius, as well to a more limited extent, neurons in the hypothalamus. It signals widely in the body through G protein coupled receptors. Now, GLP-1 is known to most of you very well as a contributor to the incretin effect. As you can see here, if you give glucose intravenously or subcutaneously, what you'll see is an increase in insulin, but that increase in insulin is far greater if you give the glucose orally. And that's because oral glucose activates the cells that make the GLP-1 and another incretin called GIP, and that leads to greater insulin secretion for the same degree of glucose, or the same glucose load. So this effect is mediated by two peptides, GLP-1 and GIP, as I talked about. And again, despite the fact that you have this effect, and you have glucose being administered, the glucose in the blood is controlled because of the secretion of insulin, and because that secretion of insulin is appropriate to the amount of glucose that's bioavailable to the body. So you see here on the right that the plasma glucose level is maintained under good control, whether you administer glucose orally or intravenously. Now, GLP-1 itself is secreted in response to food intake. So if you have a meal, your GLP-1 level goes up and it slowly goes back down again. At the next meal, it goes up. At the next meal, it goes up and then slowly goes back down, as shown here. It's also been shown to reduce appetitive drive. So here you have a meal and your satiety level goes down. But if you give GLP-1 infusion, you get a similar effect to a meal, which is that you see this decrease in satiety and an increase in satiety and a decrease in hunger. Now, GLP-1 biology is complex. It binds to cells on the pancreas, pancreatic acid cells, and it binds to beta cells, and it increases pancreatic protein secretion and pancreatic hormone secretion, particularly increasing insulin and decreasing glucagon, as shown here. And it has a number of effects. It decreases motility of the intestinal tract, so that can cause some nausea, adverse effects. It increases heart rate to a certain degree. It can cause pancreatitis, but on the benefit side, it increases insulin synthesis and secretion. It decreases appetite. It slows gastric emptying, which may have a contribution to decreasing appetite. And it decreases glucose production by the liver. Now, the pharmacological and physiological effects of GLP-1 are dependent upon the circulating concentration. So, for example, as you get just with lower concentrations, you see the pancreatic effects. With higher concentrations, you see the gastric emptying effects. And only with the very highest concentrations do you see changes in appetite and food intake. And we believe now that that's because for those effects to occur, the changes in appetite and food intake, you actually have to have GLP-1 working in the brain. So when GLP-1 is working in the brain, mostly that's from GLP that's made in the brain. But if you have high enough levels of circulating GLP, or if the circulating GLP has the opportunity to get into the brain and act there, you'll start to see these effects on appetite and therefore on obesity. Now, there are a number of different GLP-1 receptor agonists that you're all very well aware of because of their effects on improving diabetes. There's native GLP-1, of course, that we've been talking about. And if you see that, and it gets degraded so that by DPP-4, so its half-life is only a couple of minutes. There's Laraglotide, which is widely available as a treatment for both diabetes and obesity. And that's a modified version of GLP-1 where there is a fatty acid side chain put on the lysine as shown here. And there's a change in amino acid 34. And together what those do is it increases the half-life and makes the molecule more lipid soluble. And that increase in half-life to 13 hours allows the drug to hang around long enough probably to get into the brain. And when you get into it, since it's around a long time, gets into the brain, it has the opportunity to work there. A newer drug that was approved in the United States, not yet approved around the world as widely, but approved in the United States for the treatment of obesity and has been widely approved for the treatment of diabetes, is Cemagletide. And Cemagletide is an even more modified version of GLP-1. Again, you have the side chain. You've got a specialized amino acid in position 8, which blocks the ability of DPP-4 to degrade the molecule. And so what you end up with is a molecule that has a half-life of 7 days rather than 1 or 2 minutes. That long-acting molecule hangs around for a week and has the opportunity to be transported into the brain to a greater extent even than Laraglotide. And we believe that greater brain penetration is what allows it to be a more effective anti-obesity medication. You don't need that effect as much because the effect on diabetes is more directed at the pancreas, which of course doesn't have to cross the blood-brain barrier to be active. Now, if you look at the two, this is from a phase 2 trial that was published 3 years ago, and what you see here is that compared to placebo, Laraglotide is quite effective, causing an average of about 7 or 8% weight loss at 52 weeks. Semaglutide at 0.4 milligrams per day, which gives levels that are equivalent to what we use clinically today, about 2.4 milligrams per week, is about double the effectiveness, leading to about a 15% average weight loss at 1 year. Now, the phase 3 program for Semaglutide has included several studies. There are actually more than these 4 studies, but the primary ones are these 4 studies. Step 1, looking at weight loss or weight management for patients without diabetes. Step 2, with diabetes. Step 3, in combination with intensive behavioral therapy. And step 4, looking at the sustaining of weight loss with this medication compared to when you take it away. And I'm not going to go through, I don't have time to go through them all in detail. They've all been published at this point. But I want to show you that if you look at the results from these various step trials, you'll see that the average weight loss in patients without diabetes in step 1 was about 15%. In step 2, patients with diabetes was between 9.5% and 10%. In step 3, again, patients without diabetes but with intensive behavioral treatment was about 16%. It was really little different from without the intensive behavioral therapy in step 1. And in step 4, it was again about 17%, compared if you took away the drug halfway through the trial, you'd see that you actually would get weight regain. So you'd only see a net effect of about 8% weight loss. So if you look at all of them, in patients without diabetes, you see about 15 to 17% weight loss at 1 year, and patients with diabetes about a 10%, 9 to 10% weight loss at 1 year. Now, why is Cemagletide so much better than Laraglotide? It's not because it binds to the receptor better or activates the receptor better. It appears because it gets into and activates the important pathways in the brain that are necessary for controlling body fat and body weight. And I'm not going to have time to go through them in detail, but I want to show you in this slide that you can see how Symagletide gets deep into the brain. You can see this is a pseudo-colored image of a PET CAT scan. And what you see here is the regions of the brain where Symagletide gets in and where it activates neurons, that's shown here on the right in blue. So where it gets in is in purple on the left, where it activates neurons is in blue on the right, is deep in the brain, far deeper than we see with Laraglotide, and certainly much, much deeper than we see with native GLP-1. Now, as I mentioned before, the effectiveness of all anti-obesity therapies has been pretty static, with bariatric surgery being great in terms of effectiveness, becoming more safe, lifestyle therapy being effective but at a modest level, and drugs being effective at a modest level. But over the last, and so the overall effectiveness has been somewhere in the range of about 5% to 8 or 9% for medications and for lifestyle therapies. Now, that's good. It prevents diabetes, or at least delays the onset of diabetes, and can improve other comorbidities of obesity, as shown here. But one of the things that's also shown here is that for every one of these comorbidities, the more weight loss that a patient experiences, the greater the likelihood and the greater the magnitude of the benefit for that comorbidity. So fortunately, over the last 10 years, what we've seen is a steady increase in the efficacy of medications, with the addition of bupropion and naltrexone, with the addition of lorcaserin, which unfortunately, because of side effects, had to be taken off the market, because of the addition of phentermine and topiramate in combination, and because of the addition of Laraglotide. But much more recently, with the introduction of Semaglutide, this more powerful GLP-1 receptor agonist, we see now, for the first time, that the efficacy of anti-obesity pharmacotherapy is starting to move very significantly upward. Semaglutide 2.4 milligrams per week, as I've already shown you, leads to about a 15 to 17% average weight loss at a year. In combination with cagrilintide in phase 1 studies, we see data that suggests it's going to be in excess of 25%. This combination is going to be in excess of 25% weight loss at 1 year, but those data are still coming forward. And another drug by another company called Terzepatide, which is a combination GLP-1 and GIP receptor agonist, so it's a dual agonist, seems to be in the range of semaglutide and cagrilintide, meaning even more effective. So what you see here is finally, after all of these decades, we're seeing by using these analogs of naturally occurring peptides, we're finally seeing effects that are beginning to approach bariatric surgery. Now, just like all other therapies, from surgery on down to lifestyle, including diets and exercise and everything else, there's an enormous patient-to-patient variability. This is the variability for Laraglotide, 3.0 milligrams per day. You can see here to the left of the vertical black bar, some patients actually gain weight. And these are data from the phase 3 trials that allowed its approval around the world. Most patients lose a modest amount, between 5 and 10% of weight. Some patients on the far right lose bariatric surgery levels of weight. If you look at Cemagletide, you see the curve is shifted to the right. Doesn't look like much on this curve, but it's this shifting to the right is what accounts for the doubling of the efficacy. But again, you see this enormous variability from patients to patients. And for patients that you might see who have diabetes, as many as 30% of those patients will lose 5% of their weight or less. For patients without diabetes, as shown here, it's 7 to 13%. But on the other side, you'll see patients, about 35% of patients who take this drug are going to lose more than 20% of their body weight. And in the phase 3 trials, the step 1 and step 3 and 4 trials, what we see is that about 10 or 11% of patients lose more than 30% of their initial body weight, putting this drug for those patients in the category of bariatric surgery. So in conclusion, I want to emphasize that GLP-1 is a regulator of insulin secretion in the pancreatic islets and a regulator of appetite and fat mass in the brain. Some long-acting GLP-1 analogs, including Laraglotide and Cemagletide, appear preferentially transferred into the brain, which is, we believe, why they work better for obesity than some of the other GLP-1 receptor agonists. These analogs demonstrate substantially enhanced regulation of body fat, appetite, and thermogenesis, leading to a dramatic improvement in obesity. The advent of these particularly effective and stable GLP-1 agonists provides new opportunities for effective pharmacological treatment of obesity that till this point we haven't seen. These compounds represent the emerging, far more powerful next generation of anti-obesity medications. And I've talked about only a couple of them, but there are many more in the pipeline of various companies working in this area. And they create an exciting new era for the treatment of obesity. They've also been demonstrated to be particularly effective in treating type 2 diabetes and non-alcoholic fatty liver disease. And as I showed earlier in the slide, in the table that I showed, there are so many comorbidities of obesity that are likely to be able to be addressed by treating the underlying obesity when you have these more effective medications. We've already seen that bariatric surgery can have a dramatic effect on most of the comorbidities of obesity. It stands to reason that having medications that approach the effectiveness of bariatric surgery will do the same thing. Thank you very much.
Thank you very much, Professor Kaplan. So the next talk is going to be by Dr. Iba Lozeri. Dr. Iba is the Chief Medical Officer at Dasman Diabetes Institute. She's a consultant diabetes, endocrine, and nutrition. Dr. Iba is very well known to the group. She is running the obesity service. She's also the director of the Daphne Type 1 Diabetes Education Program. And she is the main center, which is the main center, is actually in Kuwait. She is a proliferative writer. She has more than 55 peer-reviewed publications and multiple other chapters in international books. So, Dr. Lozeri, the stage is yours.
Thank you so much for the introduction. It's my great pleasure to be with you all here, although wish that we were face-to-face back in life. So today I was given the title is the effective weight loss on obesity complications. So I want to show you what a double digit of weight loss can really lead to obesity complications. So this is the outline of my talk. So before we start, we really want to understand obesity. And we want to look at what is the definition of obesity. As we have seen from Professor Kaplan, obesity is a disease and it's characterized by excessive adipose fat accumulation with multiple organ-specific complications. We often use BMI as, a method of measuring obesity, but I'm sure like BMI will be obsolete in a few years and of no use apart from, for population studies. And what we're really concentrating today is the complications of obesity. So as you know, obesity is associated with multiple complications. So just trying to show you the grade and the strength of evidence, we have today more than 229 plus complications affecting almost every organ system within a medical specialties. So people living with obesity and overweight often have comorbidities, and we like to show it in the 3M models. So that's your metabolic, where you're going to have fatty livers, cancers, asthma, gallstones, infertility, cardiovascular disease, and type 2 diabetes. When we think of mechanical, we think of joint disease, incontinence, sleep apnea, chronic back pain. And when we think of the third M is the mental and well-being, and you'll see of the depression and anxiety. And the complications of excess body fat happens due to where is this body fat deposited. So if you have an increased body fat, you're going to have increased adipokine synthesis, which will lead to pro-inflammatory cytokines, impaired insulin signaling, increased insulin, and hence the type 2 diabetes. When we look at increased lipid production, you can see that it will end up in non-alcoholic fatty liver disease, coronary artery disease, congestive heart failure, stroke, and chronic kidney disease. So many of these are interrelated, and that's how it really causes a lot of the complications. So let's focus, why does a modest weight loss produce really a lot of health benefits? And the effect of weight loss in metabolic function and adipose tissue. And I hope you can see here that how much intra-abdominal adipose tissue you have versus intrahepatic triglyceride and C-reactive protein, and the degree of the reduction of modest weight loss on each of these parameters. You see, 16% loss will be equivalent to 65% reduction in your intrahepatic triglycerides. We really need to emphasize today the importance of life expectancy that decreases as BMI increases. So if you have a BMI of 40 to 50, you have only 50% chance of reaching age 70 compared to normal BMI, where almost 80% of people will reach the age of 70. And when we want to look to the relationship of comorbidities to excess weight, we see that, as this is a steep curve, and as your BMI goes higher from BMI 30 to 40 to 50, you see the increase in risk of your sudden death, diabetes, respiratory failure, and cardiac renal failure. We have seen over the years that the current obesity treatment guidelines have changed. So we have the obesity and the ACC AHA TOS guideline in 2014, which was a BMI-centric. And today we moved from being BMI-centric to complication-centric. That's again from the newer ACE and TOS and ASMBS, or the ESO societies, or the Canadian Obesity Adult Diabetes Guidelines. What we think is obesity is a key driver of morbidity and mortality. You will have, hypertension, cardiovascular disease, peripheral vascular disease. A lot of our HFpEF is today, is related to heart failure, liver and NAFLD, and pancreas and type 2 diabetes, and in kidney and CKD. So management is about improving health and well-being, not just the numbers on the scales. I'm sure many of you are aware of the Edmonton obesity staging system and of the TOS ACE obesity staging system, where we look into the metabolic benefits and the abnormalities, and again, looking into the 3M, medical, mental, and mechanical, where we have stage 1 with preclinical risk factors, stage 2 where you develop the comorbidities, stage 3 where you end up in end organ damage, and stage 4 in end stage disease. What I want to move on today and really take you through the how we really see the benefit of the weight loss on complications. I'm going to use the King's Obesity Staging Score. That's what I mostly use in my clinical practice. So similar to what we have in diabetes for A, B, C, D, F, we're going to use here the A, B, C, D, E, F, G, H, I, and I'm going to show you how at each stage will it make a difference for us from the modest weight loss that we can achieve. So A stands for airway. And if we see today, we have a randomized controlled trial of surgery versus best medicines for, airway disease, and that's for sleep apnea. And we can see the effect here on both. And also we have a large study, results coming from the scale study, from the sleep apnea results as well. So there is no need to be convinced that, a modest weight loss will improve significantly your sleep apnea. We're going to skip the B for the BMI, and I'm going to move to the C, that's the cardiovascular disease, looking at, from the Swedish outcome study, that, surgery has really a large benefit of the cardiovascular disease. Looking at also the cardiovascular outcome trial with the GLP1, in type 2 diabetes, and we see the positive significant effect on this. Also, if you want to look at the beneficial effect on weight loss, on HFpEF, and you can see that has been demonstrated, has shown a beneficial effect even in older patients with a chronic stable HFpEF disease. So this is really to show you how a modest weight loss can have a significant effect on your cardiovascular disease. Again, the resolution of metabolic syndrome after a progressive weight loss, and you can see the difference, how it's really resolved when you're looking at more than 25% of 70%. But even if we're looking at, 15%, more than 45% is resolved. If we focus on the D, so we finished A, B, C, and D, that's now I'm going to show you the effect on the moderate weight loss on diabetes. And this came from the earlier studies of the look ahead, where, greater weight loss gives a greater health benefit. And you have seen the changes in the HbA1c by percentage of weight loss category and the changes in the triglycerides by the weight loss category. And if we look at the look ahead, the outcomes with greater than 10% weight loss over all of the study populations, you have seen, this was a beneficial on, the primary outcomes and the secondary outcomes. If we move to the surgical study, we have the STAMPEDE, which have been shown as a randomized comparison of the medical therapy, sleeve gastrectomy, and gastric bypass. And the 5 years outcomes have shown that the resolution of the type 2 diabetes in overall. And this is the remission of A1C. Now we try to move from the word resolution and we favor the word remission. We have to be careful at what cutoff in the literature has been standardized, but the remission of A1C of less than 6 or 6.5 without the use of diabetes medication at 5 years. And these are results that you can see for the STAMPEDE trial. If we look at the DIRECT study, I'm sure you're well aware of the DIRECT, which was, a large randomized controlled trial that happened in the GP practice in the primary care of the UK. And we have the DIADEM, similar results in Qatar, and we have also a DIRECT Plus in Kuwait that has shown very similar results as well. So, and this is where we have taken, participants with type 2 diabetes of a BMI of 27 to 45. And you can see that if we have a double-digit weight loss, at least, more than 10 kilograms and 15 kilograms, you can put the majority of people into resolution of diabetes. And you can see here that the percentage of the weight loss and the proportion of people achieving A1C of less than 6%. If you have 10 to 15 kilograms, you can achieve up to 57. If you have more than 15 kilograms, you can achieve up to 84% of resolution. We have, DIRECT, which has been shown now for the proportion of people at 2 years and recently at 3 years results. So this is to look at A is your airway, C is your cardiovascular, D is your diabetes, and if we move next is your economic. And if we look at the health benefits from economic, this is some of the results showing, where is the percentage of people before surgery and after surgery, and the amount that increased in both economic and the means hours worked. If we move next to F, and that is functional, looking at joints problem. So weight loss in people with obesity and osteoarthritis dramatically improves your functional status. Again, if you see the percentage of the weight loss and the percentage of our improvement and the scores, you can see a great benefit in a small number of weight loss. So now I hope I have convinced you from A, airway, B, BMI, C, cardiovascular, D, diabetes, E, economic, F is functional, and next, if we move next to our King's obesity staging system, is we have the gonadal. And that's both looking at gonadal in both males and females. And we have seen that, 100% of resolution of menstrual abnormalities, normalization of sex hormone binding globulins, and significant improvement in hirsutism. So there's a lot of benefit, especially when people with PCO and other gonadal problems. And we have seen erectile dysfunctions has also improved in men. If we look at the health status, so that's moving to the H in our categorization and staging. So that's the perceived quality of life. And if we compare to people in both the surgical treatment and conventional treatment, again, you can see a major improvement in your depressions, in obesity, in anxiety problems, in social interactions, and in mental perceptions. So, we can see moving across the categories how a modest weight loss can have a huge benefits on complications related to obesity. So weight loss is associated with improvement in health-related quality of life, and that has been shown across, in many of the categories, whether it's medical or surgical or pharmacotherapy or even intensive lifestyle measures. So if we want to come into conclusion and near summary of my talk, we will see that the therapeutic weight loss really reduces complications. So it's no longer about, scale. It's no longer about BMI centric. We're really moving to looking at what comorbidity we're treating and how much weight loss we would need to get the health benefit for these patients. So it's about the health gain more than, the number on the scales. And if we go through this, if we want to prevent diabetes, you're looking at 3 to 10% of weight loss required for therapeutic benefit. You're going to see the maximum benefit at 15%. If we're looking at hypertension, you're needing about 5 to 15%. Blood pressure still decreasing at a greater than 15%. Many of the modalities today that I have shown you, whether it's direct, or the surgical, these people will be off their antihypertensive medications. For dyslipidemia, you're looking about 3 to 15%, and the triglycerides still decreasing at 15% and above. For the diabetes, we have seen today various models where we have, A1C still decreasing at greater than 15%. You have the NAFLD, where you will improve steatosis and inflammation and mild fibrosis at a 10% weight loss. The sleep apnea, with little benefit at 5%, you're going to see benefit, but you will see it even more at 10%, where they can get rid of their devices. Osteoarthritis, you improve the symptoms and joint and stress mechanics. You can improve the stress incontinence, about 5 to 10% weight loss, and GERD in males, and gonadal problems in females, and PCOS, where lower androgen improves ovulation and increases insulin sensitivity. So our obesity world has changed today. We're no longer BMI centric. We're moving into comorbidities and really moving into how do I treat and how much management we need to change for the weight loss to see the benefits. So moving from 21 to 2022, we have a lot of advances in the treatment today of obesity. And as has been shown by Professor Kaplan, is how we are moving across with the newer therapies that almost, matching our bariatric surgery. I would advise you all to look at our regional recommendation for the treatment and management of adult obesity in the Gulf and Lebanon. This has been now out from the World Obesity Federation, directed by Professor Donna Ryan, and every country is represented in the Gulf, in the region, in the World Obesity in this society. So in summary, when we come to key consideration in obesity, I hope I have been able to show you that, with a double-digit weight loss, we can have significant improvements in obesity comorbidities. We really need to think that obesity is a disease, and it's like any chronic condition. We need to think of sustainable strategy, moving into combination therapies rather than, being a simple thinking that is eat less and move more. A patient best weight may never be an ideal weight, so think of realistic goals. And management is all about improving health and well-being, not just the number on the scales. I hope that I have shown you today that modest, decrease in weight has a significant improvement in health, and success is different for every individual. So we have to think of it, whether it's physical or mental and health gains, and intervention means really addressing the root causes and overcoming the barriers. And with this, I would like to come to the end of my presentation. And I would like to thank my team back in Desmond Diabetes Institute, of the whole team. This is an institute that publishes yearly at least 70 peer-reviewed article journals. And then I would like to thank my mentors and collaborators, Professor Carl Leroux and Professor Donna Rani. And with this, I would like to thank you all. And it's been great being with you here and looking forward for further discussions and interesting questions. Please feel free to email me if you want any of the slides. Thank you and have a good evening.
Thank you very much, Dr. Iba. And thank you all the speakers for sticking to time. However, I have received just a few questions. So I'm going to start with Professor Jason. Professor Gill. Professor Gill, quick question. So, which is a personal question. My brother works from home, invested on a stand-on desk so he can stand up and work from there. Should I keep him tormented, or should I ask him to chill out and grab a chair and then go for a walk after that?
I'm not a big fan of standing desks. I think they're a solution to the wrong solution to the problem. I think sitting down for a long period of time continuously might not be the best thing to do, but you need to be moving rather than standing still to counter that. So I think a better solution would be to sit down, but set yourself an alarm. So every hour you go for a walk for 5 minutes and then you go back and sit down. I think that would have the same effect in terms of sitting down for a long time on posture and sort of musculoskeletal effect, but that will also give you a metabolic benefit. So I wouldn't bother with a standing desk, to be honest. So I'd tell your brother to sell his standing desk on eBay and get himself a nice comfortable chair, but make sure get a pair of comfortable walking shoes so he can go for a walk every 5 minutes, every hour.
I'm going to keep him tormented to stand for a few more weeks, and then I'll tell him about that. So one of the things you actually presented in your study, in the data, which is actually interesting, the study in which you put a device in the patient's pocket and asked them to stand up. And then, however, the metabolic benefits does not actually match the reported data that you actually show. There is a huge metabolic benefits in reduction of improvement in insulin sensitivity, while it seems to be more matching of what the patient reported. How accurate is your device? How happy you are with your device? Because the metabolic benefits for a very modest changes is actually I can say disproportionate a bit.
Yeah, so that's really interesting. So I'm doing another talk tomorrow, which I will cover some of those data on. But one of the difficulties is we have used data based on self-report to make all our judgments about how much physical activity people should do. And people over-report substantially how much they do. So how much they say they do and how much they actually do are two very different numbers. But what we're doing is basing our evidence on what people say they do. And actually, if you directly measure how much physical activity people are doing using one of these devices, what you find is there's huge benefits from very small amounts of physical activity. I wrote a commentary piece in Nature Medicine last year. And what it works out is, on average, 1 minute of measured physical activity during a device is about equivalent to 2.5 minutes of reported activity. So 6 minutes of reported activity is probably 20 odd minutes of actual, 6 minutes is 6 minutes of report of measured physical activity is probably the equivalent, so we saw in this, to 30 minutes of reported activity. So I think the take-home message is, don't believe what people say they do, measure what they do. But if you measure what they do, if you measure activity, the amount you need to do is actually quite small. And so if you think about in terms of designing interventions, saying you need to do 5 to 10 minutes more activity today that you directly measure might be something that people are prepared to do, and it might be less daunting than say you need to do 30 minutes. So I think if you say do 5 minutes of walking 3 times a day, but measure it properly using one of these devices, I've got one on my wrist, that might be enough. And that might be less daunting than say do 30 minutes.
All right.
شكرا Dr. Muhammad. Just if, there is one question for Dr. Professor Kaplan about for how long we can use the GLP for weight reduction for the Professor Kaplan.
So we routinely will use medications that work indefinitely for life. Now there may be a reason to stop them if there's later a problem. For example, a drug like phentermine, which if it's going to cause a problem, it's going to cause a problem early. It'll cause hypertension, or it'll cause tachycardia. We won't use it for people who are known tachycardia. But if you use it for a very long period of time, as I've used it up to 20 years, people get older, and they may you have to be aware that they may get heart disease over time. So you may have to stop a medication much later because they develop contraindications. But if you stop a medication that works well, the patient will immediately regain the lost weight. And then what we see is almost every patient who does very well with medications, who loses, 10, 20, 30, 40 kilograms, what they'll do is they'll want to stop the medication. They'll believe that the medication isn't what's doing it, is the medication is allowing them to behave better. They'll stop the medication, they'll rapidly regain weight because they've lost a lot of weight in the first place. And they'll be back in the office realizing, and I've never had a patient who does it twice, because we're selecting out the population who does really well. Now, for a patient who only loses a few kilograms on medications, we're not going to keep them on medications anyway. We're not going to ever put them on long-term medications. We're looking for medication to substantially enhance what lifestyle can do. And as I said earlier in my talk, I didn't emphasize it, but I'll emphasize it now, is we use lifestyle to fix the problem, just like we use medications and surgery to fix the problem. Just eating less doesn't fix the problem. But if you find that somebody is gaining weight or has obesity because they have sleep deprivation, or they have stress, or they have no exercise, or they have an unhealthy diet, if you can fix the underlying problem for their particular type of obesity, you may never need the medication in the first place. But that's relatively rare. So we treat it all the same way. It's just like we treat diabetes, how we treat hypertension. If the medication works, we keep them on it.
There is another question from Dr. Aipa, our colleague, for how much hemoglobin A1C reduction in case of 10% reduction of the weight? How much they affect on the glycosylated hemoglobin in diabetic patients?
Well, of course, these are good anti-diabetes drugs. And it turns out that they're also good anti-NASH drugs. So you see a benefit to that. I think that what I would say is, because of the mechanism of action of the GLP receptor agonists, you don't see a very significant degree of hypoglycemia from the GLP receptor agonist. However, if somebody is on a sulfonylurea or insulin, and they're well controlled on a sulfonylurea or insulin, and you add a GLP receptor agonist, you can throw them into hypoglycemia. It's not the GLP receptor agonist that makes them hypoglycemic. It's the insulin and the sulfonylurea, which are now overdosing the patient. So what you have to do is if somebody's not on any anti-diabetes medications, these are very safe drugs in terms of glucose control. But if they are on some that, then you just have to be careful about that. So whenever you have good weight loss, doesn't matter whether you do it with lifestyle or drugs or surgery or anything. If you have good weight loss, you have to recognize that you're probably going to put the patient at risk of being overtreated for their underlying diabetes or prediabetes. So you just have to be careful about that.
So just to comment on this is you have seen that about 10% weight loss can put people into resolution, to remission. So we have seen from direct 10 to 15 kilogram weight loss can put people into remission. But we have to take into account that they have to be early into disease, similar to results that of the bariatric surgery. Your chances of being into remission is less if you have been treated on insulin and you have some, reserves on with C-peptide. Of course, in clinical practice, we have seen people who have been in megadoses of insulin have been taken off, the insulin, but they have a less duration of diabetes. So we say your chances is higher if you have a duration of less than 3 years of diabetes. Up to 6 years have been reported in the literature as well.
Yeah, I think that's very important what you're saying. And I think it's also important to note, though, and this talks about the role of the regulators and the governments in deciding how various treatments are covered. You save a lot more money if you get somebody off of insulin and they're on only oral agents than you do if you've got somebody who is never on insulin and you put them in full remission. So the surgeons love to talk about full remission, but full remission is a concept. Getting rid of insulin is a real benefit to the patients and in terms of risk, in terms of cost, in terms of everything. So while I agree with you that going into full remission is much less likely if a patient starts on insulin or has had diabetes for a long time, the actual net benefit to those patients may be even greater than the net benefit to the patients who get caught early. That's not to say you shouldn't catch them early, but if you don't catch them early, it shouldn't be a reason not to use surgery or any other effective therapy.
And I can tell you data from our remission clinic in Kuwait that, more than 70% of people who achieve weight loss would be off their insulin therapy, even if they had insulin for a long time. And that's, exactly what Professor Kaplan has shown, demonstrated to you as, this is a huge benefit, even if they don't reach remission, but getting people off their insulin therapy when they're on 300 units, just by, pharmacotherapy or losing weight is a health cost benefit and economical benefit for the country.
I think, Dr. Aiba, you're talking about type 2.
Type 2, yes.
Absolutely.
Although there is some evidence now for type 1. So there's growing evidence for type 1 that we don't have time now to go into in detail, but a lot of patients with type 1 now have obesity. And some people call that type 3, they call it type 1 plus 2, but type 1 is not a disease only of skinny people, the way we thought about it maybe years ago when we were trained. So I think that we do have to consider that the growing population of people who have a need for treating insulin resistance in the setting of type 1 diabetes.
So we have actually just published last week in Diabetology, and there was a presentation in the ESD. I'm one of the co-authors in the Lancet Diabetes Endocrinology, a review on how to treat obesity in type 1 diabetes and, the various factors of obesity around different part of the world. So I would urge you all to look at it, Diabetology it's a Lancet in the Diabetes Endocrinology presentation that was publication was published last week, and it was in the ESD conference presentation.
I think because of the time, we'll move to Dr. Gill, because there is one interesting question. For how long do you advise type 1 diabetes? What's the maximum times for exercise? Because we noticed some patients, they develop hypoglycemia after exercise in type 1. So what's the maximum time you advise your patient for doing exercise in type 1?
So I don't think there's people with type 1 diabetes who are professional athletes, professional cyclists in the pro peloton, professional footballers. There's no maximum amount of activity that someone with type 1 diabetes can do, and I don't think they should be limited in the amount of activity to do. What we need to do is understand how physical activity influences their glucose levels and how it interacts with insulin. And one of the issues in type 1 diabetes is the intensity of activity you do actually has opposite effects on your glucose concentration. So if you do long, steady activity, that causes your glucose levels to fall. If you do sprints or high intensity activity, it causes your glucose levels to rise. And so just being aware that different types of activity have different effects. And also the order which you do. So if you have a session where you do some long, steady stuff and some sprints, the order that you do them in has a different effect on what your glucose is, both during the session, but also into the hours afterwards, and particularly into the night. So it's getting some awareness of what happens to your glucose, and actually understanding how much you have to change your insulin. And one of the things with insulin is you say, well, look, if you're going to do some exercise, you need to reduce your insulin a bit. You don't have to reduce your insulin a bit, you reduce it a lot. You take it to 25% of your normal amount. You don't just drop it down a little bit. So it's actually understanding how your activity interacts with your insulin and understanding how different types of activity actually have opposite effects on your blood glucose that you need to take into account. But with that knowledge, there's no reason why you can't run marathons and be a professional cyclist or do whatever in terms of activity if you have type 1 diabetes. It's just a little bit of knowledge and understanding is what you need.
And I think the auto insulin pump, it will be very helpful in this situation, especially in the exercise. So because it's auto, the amount of the insulin pumping, it will be changed according to the blood glucose level. Yes, Dr. Aipa?
I just want to add is last year we have conducted a study with a collaborator from Professor Gill lab team is looking at the timing of exercise in type 1 diabetes while fasting in Ramadan, and the different effect of exercise. So while people are fasting, when do you time it, and how does it have an effect into Ramadan and exercise? So as Professor Gill said, people with type 1 diabetes, a lot of them are professional athletes. It's all about managing, insulin therapy and what exercise we advise people and in what orders and the timing of the day. So there was, very interesting results that we have seen from last year Ramadan study looking at timing and exercise in type 1 diabetes.
Yes, Dr. Muhammad, if there is any other question?
Yeah. So can I ask Professor Kaplan? Taking a skeptic kind of a stand about the long-term use of GLP-1 agonist, which is related to, number one, cost on the long term, number two, compliance. So some of the studies, like, for example, scale diabetes and pre-diabetes, in the extension of the trial, they lost about 50% of the patients. And remember, those people were getting the medications for free, if I'm not mistaken. So in your kind of setting, what are the compliance rate on a longer term basis?
So it is true that they were getting it for free, but they were in a trial. They didn't know how much weight they were going to lose. When we talk about the scale trials, we're talking about a much weaker GLP-1 receptor agonist than we see in the in Cemagletide. And so there's a number of things that would cause me or anybody else to say, I'm not getting enough benefit from this to keep going, even though it's free. Then when you get to the real world and it's not free, it's very expensive, then you've got an issue of access, and you've got an issue of equitable access, which is really a problem for these newer drugs. But a few things are going to change, and I think that's what we really need to think about. One is what we saw in the STEP trials was that a lot of people lost a lot of weight. Again, remember, a third of people lost more than 20%. And what happened was that, what happens with these drugs is it lowers the amount of fat the body wants to have. What the body cares about is how much fat it has. It doesn't care whether it's hungry or not. It uses hunger as a tool. But if it wants more fat, it gets hungrier. If it wants less fat, it gets very much less hungry. And so what happened was these patients lower the amount of fat that they want on the drug, sometimes by as much as 25 or 30 kilograms. And then they had to take the drug away because it's the end of a trial. This is a trial of a drug that was not approved. So therefore, everybody had to have the drug or the placebo taken away. And a lot of patients complained viciously to the PIs that they were hungrier than they'd ever been. Well, of course they were, because they're now so much lower than their original weight, which was induced by the drug, but now they're lower than their original weight without the drug, so their body wants to regain all that weight. And what does it do? It gets extremely hungry, they crave. So what's going to happen is that's going to drive long-term use in the patients who do the best. The second thing that's going to happen, which I think is very important, is Laraglotide is going to go off patent over the next few years. And there's a better drug, Symagletide, but the whole world can still use Laraglotide. And Laraglotide is still a good drug, not quite as good as Semaglutide. And what we're going to be seeing is with Terzepatide and with Cemagletide and with Danuglipron and all these drugs, is over time, we're going to see, as with every other field, there'll be generic ones, there'll be inexpensive ones, and they may not be quite as good as the very best ones, the Rolls Royce of drugs, but they will be available to large parts of the population. I want to emphasize, if a patient doesn't lose weight on a drug, they shouldn't stay on the drug. There's no value to that drug. All the drug is a toxin. But for those patients who, doesn't matter whether it's a drug that typically causes a lot of weight loss or a little, if an individual patient loses a lot of weight on the drug, that's the time when you keep it on. You don't do it just for the joy of it. You do it only when it works.
There is a maximum dose for GLP generally, because every time we see some of they change the maximum dose, like the Laraglotide, Cemagletide being increased the doses. So
the reason that they changed the maximum dose is because they're developing it for obesity. In order to get the maximum effect for obesity, the drug has to get in the brain. That's what I was saying earlier in my talk. It doesn't work just on the pancreas. So therefore, you need a higher dose and you need a longer acting drug to be effective in the brain. Because the normal GLP-1 that works in the brain is made in the brain. But the GLP-1 that's made in the gut doesn't usually get into the brain. It only lasts a couple minutes. It never has a chance to get in the brain. So these drugs, in order to get in the brain, you need a higher dose of them. And in order to get in the brain at enough dosing to actually have the maximum effect, you need a higher dose. The only reason there are two different doses is because one dose is as effective as necessary for diabetes. The other dose is needed for obesity. And of course, then there's all kinds of other reasons. There are economic reasons why they separate them, but that's a separate issue. But the reason there are two doses is because it does take more of the drug to cause the weight loss.
Yes, Mohammed.
Great. So if I take a hypothetical kind of question that you have an identical twins and everything is the same, one is heavy and active, the other one is normal and sedentary. And we've had to talk about activity with no cover of the weight, and we have a talk about the weight as well. So which one of them is at high risk of complications in the long term? The higher weight and active or the lower weight and sedentary? Same risk factors.
I'm going to defer to Dr. Gill on this, or Jill. I don't know if you pronounce your name Jill.
Yeah,
Gill,
for diabetes complications, weight trumps.
Let's talk about metabolic complications.
Metabolic complications, weight trumps activity. So I think you're better off, despite being someone who's an activity person, you're better off being normal weight and inactive, I would say, than being heavier and
active.
Heavier and active, I think, on average.
Can I add to that? This is a false dichotomy. There is nobody who can't exercise in some way, even if you're paraplegic. And so this idea that one has to be more important than the other is not clinically relevant. If you're a thin person and you don't exercise, start exercising. If you have obesity and you don't exercise, start exercising. Now, it would be nice if you have obesity with these newer therapies that we have to become thinner. But these are orthogonal. This is y-axis, x-axis. You don't have to, neither one interferes with the other one. So therefore, don't get into this sort of false debate. The important debate is, are you doing as much as you can be to make yourself as healthy as possible?
Yeah.
That's really what you ought to be doing.
Thanks, Dr. Kaplan. So I sometimes give that answer and saying that basically is diet more important or physical activity? And I say, look, the evidence is both together is better than either on its own. So you do both. I guess it's a slightly different question. So if your person is obese and active, will they gain more from also losing weight, or are they okay being active if they're obese? And I think the answer is they probably should try and lose weight as well. I think there's sometimes an argument that activity is the more important thing, that if you're obese, as long as you're active, you're okay. And I think the evidence suggests that's probably not quite the case. An obese active person is better off than an obese inactive person, but a normal weight active person is better off again. So I think you're absolutely right that doing both things together is important. But the obese active person is doing something, they probably should lose weight as well to maximize benefit.
I agree with you completely. But I would say that we also have to remember, and this is an agreement with you, that most studies that look at lifestyle, particularly about exercise, are short-term studies. We don't know how long. So even then, even to expand what you're talking about, we don't know what the long-term effect is. That's number one. And so you really do want to lose the weight on top of being active. Number two, we also recognize that there are more than 200 comorbidities of obesity. We focus on diabetes and all the metabolic ones, but there are many others that are not improved by exercise. All of the cancers and the metabolic are improved by exercise. But there are other ones that you need to lose the weight to fix the knees. You need to lose the weight to be eligible for a transplant for your kidney or your liver. You need to lose the weight for other things. So there's a lot of reasons why by being fit but still having obesity is only part of the solution. I'm just agreeing with Dr. Gill.
That's perfect. Dr. Iba, I have one last question regarding the use of the King's scale in the clinical practice. How do you incorporate it in your activities? This kind of a checklist going through complications, or how do you use this in your clinical practice?
So in every patient that we see, we stage them with A, B, C, D. So, and we have probably shown you in the beginning. So we would ask about airway, sleep apnea. So this is through, questionnaires. So it's either Epworth or the stop bank, depending on, where are you are. And then we have, you would measure the BMI in these people, so you would report it. And then with each, whatever we have put them on a modality, so whether we put them on lifestyle or in combination or pharmacotherapy or surgery, you would see how they have moved across. So people who would have sleep apnea might have been resolved. So in every patient that we see, we would put them airway, BMIs, cardiovascular, diabetes, economical, F functional, and we have added more to it. So, health. Do you see yourself healthy or not? What do you see when you see yourself in image, in the mirror? Then we have added to it junctional. So do you have a gastroesophageal reflux? We have K kidney diseases. So they have kidney stones. What's their EGFR? Then we added L as liver. So what is their stages in the liver? And then we added to it is M as medication. So every patient that I see in the clinic, we've put it all as a team, no matter who is in the team that's seeing these patients, and that's the easiest way to move through the modalities. And we have the scoring to it associated with it as well. So you can see it moves from 3, 2, 0, 1, and you can see how things has improved. And it's easy things to ask every member of your team. They can use it, and we see a benefit to the patients as well.
Not sure we have any more questions. Dr. Abdurrahman, do you want to wrap up the session?
Yeah, I think thanks for all of you. Thanks for our speaker for very interesting, very informative session, and for all the discussion. Thanks for our co-chairman, Dr. Muhammad. And thanks for organizing a committee and scientific committee for selecting the speaker and the session, which is very interesting for all of us. Thank you for our audience. And I think we'll move to the second session, and we'll see you, inshallah, قريب بإذن الله. شكرا. Thanks for all of you.